Okay, so I think it's quite a good case. It's going to be quite testing. So I think, should we just try and agree what the key issues are in terms of the various skills?
Absolutely. So this is a gentleman with hyponatremia, and I would expect candidates to be thinking firstly of neoplasm.
Yeah, I mean, for me, although maybe the scenario suggested the drug was the issue, but the key thing here is to consider malignancy, because I think that's probably possibly the most likely diagnosis, yes, but also the most important one to exclude, even if it isn't.
Absolutely, and he gives a clear history of upper GI symptoms, so I would expect a good candidate to explore that further.
Yeah, so in terms of the clinical communication, I think the key things probably in terms of we want to get out of it is to explore the possibility of malignancy, particularly GI malignancy.
Absolutely. Yeah.
And also to obtain the drug history of the proton pump inhibitor, the omeprazole, which is obviously potentially one of the causes.
Absolutely. And I think as a third consideration, I think they should be thinking about hypoadrenalism, Addison's.
I think you have to, because as an endocrinologist, I would certainly say that's quite important. But I think with this low sodium and lethargy and the weight loss, then Addison's disease has to be on the differential diagnosis here.
Absolutely.
So explore those three things, and I think that will give us enough for the clinical communication. Then, in terms of just going through the skills in the physical examination, when we get to that, it's really going to need to reflect those possibilities. So I think they're going to have to do a fairly comprehensive examination in terms of checking for fluid status, the volume status, fluid volume status. They're going to need to do a chest examination and an abdominal one, and look for lymphadenopathy. So there's 4 key things for me. I
would absolutely agree. I think the history quite clearly states that the neurological examination is normal. So I think if a candidate is wanting to do a neurological examination, we should stop them. They're not going to have time.
No, I think that's fine. I think we just remind them and say it's normal, you don't need to do that, it's not going to be helpful. That's fine.
Yeah.
So then if we perhaps move on to managing patients' concerns, which I think the surrogate's going to be primed really to say that he's pretty worried he might have cancer.
There are certainly a couple of questions. So one of the questions is what's going on? I'm worried. Mm-hmm. Could this be something serious? And the patient will want to have some discussion on what will be the next steps. So some discussion on what investigations are going to be done is, I think, quite important. And also to get an idea of when to get the patient back, because clearly follow-up is going to be important, and repeat blood testing is going to be important as well.
Yeah, no, I agree. So I think the key thing there is to actually acknowledge that concern, to acknowledge that it is actually a possibility. So it's certainly not to just exclude it outright,
yes,
but also to provide some reassurance that there are other equally possible diagnoses, and that the quickest way to sort it out is to organise some tests, to give them a lifeline in terms of, we're going to do something about it. So what I wouldn't want is the person to be left at the end just thinking they might have cancer and they don't know where they're going.
Absolutely, yeah. So I think that safety net is quite important, that the patient knows that there's going to be follow-up and reassessment.
Okay, so that's almost brings us into the clinical judgment within the interview, although we can explore that further in the discussion, because actually that's all going to be about the investigation plan and the management plan. So the two, hopefully, with a good candidate, will merge into one.
Absolutely. I think it's quite important that the candidate identifies that the proton pump inhibitor could well be the cause, and they should say that they would stop the proton pump inhibitor, and that they would give an alternative. So H2 antagonists.
So are we going to make that an absolute requirement for a satisfactory on that, do you think?
Yes, I think we should.
I think we probably should, yeah. And then in terms of the other clinical judgment issues, there's a lot of things you could do, so we need to be careful not to require everything. But I think in this situation, a lung cancer is a pretty possibility here, even though he's a non-smoker. So I think a chest X-ray would probably be pretty important. And I think they need to actively consider adrenal insufficiency. So very least a 9 AM cortisol, but possibly a short synaptin test. And certainly if we're going to make a diagnosis of SAADH, that's going to be necessary anyway.
Sure. And I think they should be considering a serum osmolarity and urine also, and urinary sodium would be helpful.
And they haven't been given the hemoglobin, so they need a blood count, because again, with the history of tiredness and lethargy and possible GI things. So
agreed.
And then there are lots of other things that you could do later on, depending on what they show, but I think they would just come into the general discussion. So I think those would be the core ones we were looking for in the clinical judgment. So does that feel
That
happy with
sounds,
that?
yes. I think it's important that the candidate finds the clinical examination to be unequivocally normal.
Yeah, I think you need to tell us it's unequivocally normal and specifically tell us what the volume status is, so that the physical finding is that he is euvolemic, which in a way is a positive finding, not,
Yes.
okay, that's a normal finding, but nevertheless it is a positive
Yes.
finding in this context.
Yes, and I think we should specifically ask about fluid volume status.
Yeah, if they don't proffer it, then we can explore it. Yeah,
Agreed.
I'd be happy with that.
Yeah.
And we've already agreed what the differential diagnosis is, basically, haven't we, in terms of malignancy.
Drug history being
drugs.
important, so could it be the omeprazole and hypoadrenalism?
Yeah, so it's basically malignancy, hypoadrenalism, SADH, and then it's the causes of the SADH, which is really either malignancy or drug are going to be the top causes.
Yes, absolutely.
Okay, so that seems reasonable. So I think all we really need to do now is just actually examine the patient.